I'm standing between you and lunch, so I'll do my best here. It's a very powerful position. I didn't really introduce where I'm from. I'm from the University of Minnesota, and that is the coldest state in the United States, although this room is a pretty close contender. So,
we have increased temperature.
Okay, well. I have to say that the conference organizers are very responsive to your needs, because this topic was generated from people that were in the audience and asked for it. So this is a topic I know a little bit about, but it's a new presentation for me. Beyond Bellyaches, the implementation of FODMAPs in clinical practice. So here's our outline. We're going to give some examples of the FODMAPs definitions, talk about prebiotics, tolerance, and then a little bit on irritable bowel before we get through here. So this is I really appreciate the conference, so evidence-based that it is, and all these references are there. So as I go through this, I may go a little quickly, but it's all going to be able to find it. So what happens in the digestive tract? So this is how complex it is. So if you've worked in digestive issues at all, you know that it's very complicated. It's not just the diet. There's other things to think about. But here's what's going on in the lumen, the intestinal wall. And then as you go down there, you can see just all these interrelationships between the food and everything that's going on. So we're going to talk mostly about the food today, but just to start out by, it's much more complicated than that. Certain people, they tolerate the food really well. The next person will not, and it's because of these differences. So some definitions on carbohydrates. So carbohydrates, you're going to eat carbohydrates, and what are you going to get exposed to? Well, chemically, they're monos, they're dis, oligo, and polysaccharides. And when we talk about FODMAPs, that's really what we're going to talk about. Chemical, then we go down to nutritional. How are they different? Do they get absorbed, yes or no? Are they digested? Can you break the bond and split them so you can get them in? Are they fermentable? And this is what happens in the large intestine. So a lot of what we talked about fiber is this fermentation. We said like wheat bran, about half of it is broken down with fermentation. Things like inulin phos are 100% broken down. So every fiber, how much gets broken down in the large intestine or fermented. And then there are some fibers that really don't get fermented hardly at all. So there are things like purified cellulose, pretty much go straight through. There's no fermentation. So every fiber is different, how much gets broken down, and we don't have great data on a lot of that. Physiological, you've heard a lot today about is it low glycemic, is it non-glycemic, how does it affect blood glucose, how fast does the blood glucose go up, how long does it stay up? So every carbohydrate is going to have variations in that too. Fermentable carbohydrates, so that's anything that is incompletely digested or absorbed in the small intestine. So, obviously starch, most of it gets broken down. If it escapes digestion, it's resistant, so it's going to get down into the large intestine. What happens there is this fermentation by bacteria and some of the products, so short-chain fatty acids being a product of that fermentation, and gas production. And it can either get excreted in the feces if it's not fermented and goes straight through. So what is a FODMAP? I didn't have anything to do with this, but it was just there's a reference there from the Academy's journal that there was a review in there. So I think now you're going to hear more questions about it. But it's an acronym that stands for fermentable, oligo, di, and monosaccharides, and polyols. So it's like really fairly difficult, but just remember it all is carbohydrate that's low digestible carbohydrate, so for some reason it escapes digestion and absorption. It was, the term was coined in 2005 by Australian researchers who theorized that foods containing these carbohydrates worsen the symptoms of digestive disorders, and typically when you read in this literature, irritable bowel and inflammatory bowel disease. And in these cases, a lot of times these carbohydrates are, it's suggested that you eat less of them or exclude them from the diet. So what are some examples of these oligosaccharides? Fructooligosaccharides and galacto-oligosaccharides. And we're going to transition this in the end that these are the prebiotics. So when we talk here, the whole FODMAP thing is getting rid of these things that actually are the prebiotics. So it's a bit of a conflict here that there could be, depending on your patient or who you're working with, to tell people to get FOS and GOS out of the diet has some negatives as far as prebiotics. Disaccharides, lactose. Lactose, most people, if you have enough lactase around, lactose does not escape digestion absorption, but if you are any type of lactase deficiency, then lactose is essentially like a fiber. Gets down to the large intestine and gets fermented. Lactulose is another carbohydrate that actually gets down there. Monosaccharides, this is something you don't eat much of. So fructose does not appear in most foods at all. Look at food sources, things like pears and apples are pretty high. But fructose as a freestanding carbohydrate, not much of it in the diet, but you could put it in the diet. You can go buy it, put it in any formula, so it's possible to be there. And then just polyols. So sugar alcohols, the advantage of sugar alcohols is you get a sweet taste, but they don't give you 4 calories per gram. I was talking in the other system, but because they're slightly digested and absorbed, you get the sweet taste, but you don't get the number of calories that you would get. So as we go down this, as you're saying, well, why do we use all these low digestible carbohydrates? Because, calories. People want to reduce calories so that we still get the sweet taste, but we can reduce calories. Absorption, what happens with oligosaccharides? You don't break those down. You don't have the bonds to break those down. So you eat fructooligosaccharides, galactooligosaccharides. They're pretty small little compounds, usually they can be anywhere from 3 to 10 monomeric units, and what happens is they go straight through. So in the small intestine, you don't have the digestive processes to break those down. Disaccharides, if lactose is something that, if I'm lactose intolerant, that's going to get down to the large intestine. If I'm not, it's going to get digested and absorbed. Lactulose, which is the same thing as lactose except as a beta bond as opposed to an alpha bond, you're not going to be able to break that down. So if you're looking at breath hydrogen, how do you move things through the intestine fairly quickly, lactulose is pretty much an explosive thing because it goes right through you. All this fermentation takes place, breath hydrogen goes straight up, and usually the end result is diarrhea. So that would be a case study of what we're talking about here. Monosaccharides, things like fructose. Very little fructose is naturally occurring in nature. You don't eat much monosaccharide, but if you do eat more of it, it gets slowly absorbed if it's consumed alone without a balance with glucose. So a lot of fructose will actually cause some digestive disorders. And then polyols are incompletely absorbed, so they also get down to the large intestine. Remember, as we go through this too, a lot of this has to do with how much you take in. So, a little bit of any of this is not going to cause problems. If you have a lot of it, this is where you run into problems. So polyols, I don't know what the rules are in South Africa, usually can be used in sugar-free gum, sugar-free candies, and you don't eat tons of them, so it's not, for the average person, it's not a big disorder, but for people that have more digestive problems, it's something to be concerned about. These different FODMAPs have different absorptive patterns and physiological effects and shouldn't be grouped together. So this is kind of the contrast here as people say, let's put all these together because essentially it's the same thing. And other people say, well, putting sugar alcohols with oligosaccharides, they're pretty different. But the FODMAP concept is let's put them all together, and especially when we're going to look at exposure. If people have problems, what is it in the diet that might be causing problems? And any of these could potentially be a problem for people. So examples. Fructooligosaccharides are fructans, and I mentioned this is a degree of polymerization 2 to 9 units. Inulin typically is greater than 10 units and much longer than that. Where do you get it? Well, the food sources are down on the bottom. So inulin, fructooligosaccharides occur naturally in a lot of foods, but a lot of what's in food supplies are isolated from compounds that are really high. So chicory root, Jerusalem artichoke, those are naturally high, and so if you go out and look at inulin that's in a food product, typically they'll take chicory and isolate it and concentrate it. Food sources though, peach, watermelon, fruits, different things, onions, wheat, are all sources of fructooligosaccharides or inulin. In a normal day though, you don't eat enough of it for the average person to have any real negative consequences of that. Other oligosaccharides, galactooligosaccharides are found in human milk. So when we think of bifidobacterium, breastfed babies have the highest amounts of bifidobacteria in their fecal samples, and there's a lot of galactooligosaccharides in breast milk. It also can be isolated and added either to infant formula or other foods. So galacto-oligosaccharides are also prebiotics. We'll talk about that later. And then there's these other oligosaccharides that are naturally found in different foods. Typically, legumes is a big source. So kind of the standard joke, if people eat too many beans, they fart. I mean, that's like everybody knows that. So why is that? Because a lot of legumes have these types of oligosaccharides that are just poorly digested and absorbed. Sometimes by cooking, things like that, processing, you can actually increase the digestion and absorption of those oligosaccharides that are naturally in those compounds. A lot of times too, that's why people don't eat those compounds. We want people to get more fiber in their diet. Legumes are a good source, and they'll say, I'm not going to eat it because of intestinal gas. Well, there's some positives with that. We want to get people eating more fiber. Which the disaccharides, lactose obviously is an example of that, but it's only a FODMAP when I don't have enough lactase. So for most people, it's not. For a person that's lactose intolerant, it can be. And these are hard things to figure out. I mean, obviously, we don't have a lot of clinical tests that are readily available to get that figured out. It's more common in certain ethnicities. And highest lactose exposure is from milk, obviously. But if you look at where else, what's interesting here in the studies that have been done, there's going to be some in ice cream, yogurt, soft cheeses, but yogurt is typically absorbed better than some of the other ones. Some people think it's because there's some enzymes in yogurt. So even a lot of lactose intolerant people, they can take in small amounts of lactose. They can take in certain food products much better than like a ton of skim milk. Obviously there's the most lactose in skim milk. So if you give a large volume, you're most likely to cause problems. Monosaccharides, free fructose. I said it's not around much. If you take it in higher quantities, then glucose absorption is impaired and malabsorption can occur. The advantage of fructose, it's like, why did we ever kind of isolate fructose? It's very low glycemic. So I give always the example, like Frosted Flakes are much lower glycemic index than straight corn flakes, because starch is the highest glycemic, fructose is lower. So if you want a lower glycemic index, put sugar on anything and it goes down, which seems really wrong to people, but it's exactly right. So a lot of glycemic index diets where they really want low glycemic, they give fructose. But what foods are naturally high? Apple, pears, and if you get into kid nutrition and you're trying to treat constipation in kids, if you give apple or pears, because of fructose, you get some malabsorption, can actually get things moving through. For somebody who's not wanting that, too much fructose can cause a problem. Polyols, lots of them out there, all of the OL at the end, so erythritol, xylitol. They're slowly absorbed, and about a third gets absorbed, so they're not calorie-free, but they're low-calorie. There's some naturally occurring polyols in food. Most of your exposure is going to be because somebody put them in as an artificial sweetener, but they're also in some food products. And sugar-free gum, sugar-free candy typically has polyols as the sweetening agent. So what are the benefits? Well, why do we use, as we go through this, you're like, well, why are all these things used? Well, they cut down on sugar, and some of like inulin and some of those products actually cut down on fat. So to reduce calories, all these products have a potential ability to reduce calories. I've already heard about the obesity issue, so every little way of reducing calories is of interest. So all these products typically will have different types of FODMAPs, whether they're fructooligosaccharides, whether they're polyols, different ones can be used, or a mixture can be used. Benefits, lower calorie. They're not calorie free, but they have some calories in them, and it's really hard to even decide from the labeling side how many calories you have to take. So the sugar alcohol is usually in these are, you can see the kilojoules versus kilocalories here. Advantage, low glycemic response. They don't cause tooth decay, so that's why they're in sugar-free gum. They're actually prebiotics, so the whole issue of trying to increase bifidobacteria, fructooligosaccharides, galacto-oligosaccharides are very successful at doing that, and other potential benefits. So I want to talk a little bit about prebiotics. This is kind of my area. So I mentioned before that most people don't want to collect fecal samples and measure stuff in it. So at the end of the day, Why haven't prebiotics moved forward? Why hasn't there been more interest in probiotics and prebiotics? We just don't have a lot of evidence-based reviews and evidence-based to support it, because we don't have, like the Nurses' Health Study, we have dietary exposure on those women, we have blood samples, we have urine samples. There's a lot of questions we can ask. We can't ask about stool weight or what's their bifidobacteria, because we don't have any data on large data sets like that. So it's a little bit limited. But I think where the interest is going to go is that the gut microbiota is now being linked to obesity and other health benefits. So I think that's going to really expand interest in looking at the gut microbiota, changes in bifidobacteria and other microbiota. So I think you're going to see a lot more interest in this area. And this is just a review that was published on just this interaction of how this could potentially work. And it's really complicated. And it's like everything, once people get interested, they think, oh, this is going to be the ticket, this is where everything is, and then they get into the area and they go, wow, this is pretty complicated. How do we measure gut microbiota? What are our methods? How much do we know? Because remember, those fibers, as they get fermented in the large intestine, what gets produced? Short-chain fatty acids. What are short-chain fatty acids? They're fat. What do you think they give you? They give you calories. So that's why when fibers get fermented in the large intestine, that's not a 0 calorie. There's some actual calories that get generated there. So this whole concept of fermentable carbohydrates in the large intestine and its role in obesity is quite complicated, very difficult to study. So a little bit on inflammation too. Low-grade inflammation contributes to the development of obesity. We know that the gut microbiota alter energy metabolism and play a role in immunity. Some evidence that fiber fermentation in the gut provides physiological benefits, increased mineral absorption. So one of the advantages of inulin is that you actually increase calcium absorption. Same thing with lactose. A little bit of lactose malabsorption actually increases calcium absorption. So a little bit of this fermentation lowers pH, is thought to increase calcium absorption in the large intestine. Prebiotic effect we'll talk about, and then just kind of getting bad bacteria out and good bacteria in. So this pH issue of, as we lower pH, we actually increase bifido, decrease Clostridia and other bacteria that are considered not as friendly. And then just the colonocytes need energy, so butyrate. So you've heard the story about short-chain fatty acids, butyrate being a preferred energy source for the colonocytes. This whole fermentation being important there. I'm going to kind of point out that prebiotics fit into this story, and this is why when we say let's get, FODMAPs are bad, let's get them all out of the diet, we got to go, well, actually, that fermentation has some positive effects. So before we do that, let's think about this. Prebiotics are non-digestible food ingredients that beneficially affect the host by selectively stimulating the growth and/or activity of one or a limited number of bacteria that can improve host health. So these are things like fructooligosaccharides, galacto-oligosaccharides that escape digestion and absorption in the upper GI, and then they actually generate lactobacillus, bifidobacteria, and are thought to give you a healthier composition. Which ones actually are? Now, if you could make yourself a prebiotic, it's a pretty nice thing to be. So a lot of fibers saying, hey, I'm a prebiotic, I'm a prebiotic. This was a review by Dr. Roberfreud, and he said really only fructooligosaccharides and galacto-oligosaccharides qualify. Other people would disagree. This is another review article, and they said all these have some data to show that they are prebiotics. So beyond inulin, and inulin, remember, is just the big chain of phos, so they're basically the same thing, except that it's chain length different, galacto-oligosaccharides, but a lot of these other oligosaccharides have been shown to be prebiotics. There aren't good methods to say, okay, I'm a prebiotic. So you typically have to do a human study, show that you increase bifidobacteria, and because there's lots of methods to do that, there's quite a bit of controversy. I wanted to mention too, like for EFSA, when they looked at all the prebiotic, probiotic claims, none of them passed muster. I told you this morning that wheat bran has a claim in EFSA because it increases stool weight, but there are no prebiotic or probiotic claims, because they felt that the scientific evidence was not there to move forward. So as we go down this path, remember, a lot of disagreement there. No prospective cohort studies that link changes in microbiota with health outcomes. We just don't have that kind of data like we have for cardiovascular disease, obesity, So we think that Bifido is good, but to prove that, and this is where EFSA was missing the link, that we don't, if I increase your Bifido, okay, I can do that, I can give you fructooligosaccharides and do that, but am I going to prove that that's going to have a health benefit? We just don't have the data to show that right now. There's lots of disagreement on how to measure microbiota in human studies. Lots of different methods, classical methods, more novel, quantitative methods. There's lots of disagreement on that. There's no prebiotic standard protocol. How do we get, what type of study do you have to do? And this is really why I brought this in, that long-term restriction of FODMAPs may lead to a decrease in prebiotics. So they're kind of issues going at the opposite end. So if you get rid of FODMAPs, you get rid of the prebiotic carbohydrates that are out there, and that may have more detriment depending on who you're talking to. So some of the research limitations. We don't have a lot of fecal samples, and then what is the right way to come up with the standard? So on the bottom, I want to mention quality of life is really where a lot of studies are going. Because if if you have diarrhea or constipation, your quality of life suffers. If you have irritable bowel, your quality of life suffers. So we're not going to collect fecal samples on a large group, but getting data on quality of life. So if a dietary exposure helps quality of life, then we can go with that as a indicator of success. What happens with gut fermentation? Well, lots of things, obviously. Bloating, distension, gas, and diarrhea. So getting that balance of what's the appropriate amount, how do we want to normalize stool chemistry as much as possible. Typically subjective methods. A lot of studies are going to subjective methods, asking you, do you have these symptoms? How do you think you measure intestinal gas? I don't think if you ever get a potential to do it in a research study, you probably don't want to do it. It's actually, you hook people up and you collect it and then you analyze it. So it can be done, but it's probably the subjective idea, does this give you gas, is probably the kind of data we're going to have. And then what do people find acceptable? Even do you have diarrhea? Do you have constipation? What's normal? Very subjective, but probably the best data we have, and that's a lot of what we have. So some of the FODMAP recommendations are based on clinical observations, not randomized controlled trials. So we go like, what's the evidence base? It's pretty limited because we don't have a lot of randomized controlled trials. So tolerance. Different things that affect it. I mentioned before that, is any food going to cause you an effect or a problem? It has to do with how do you consume it. Is it with a beverage? Do you consume it all in one big group? The background diet. What's your background diet of FODMAPs? What are you typically consuming anyway, and what else are you taking? So what happens to an antibiotic? When you take an antibiotic, what's it do? Wipes out your microbiota, gone. So if you're on an antibiotic and you're on a FODMAP, you're going to have a really different effect than if you didn't. Obviously laxatives and other things that are going to affect that. And then just who's your person, who's the host, so your age, your gender, your psyche. Some really interesting new data on just the personality. Mood is probably one of the most important things affecting gut health as opposed to diet exposure, things like that. So other things to think about. Assessment. This is a hard thing. It's mostly going to be, you're going to ask a person and they're going to give you the data. So stool samples, most people don't want to collect them, most people don't want to analyze them. So there is not a big research base there. I mentioned you can anal gas, you can collect it and measure it. Abdominal girth, which is really hard to do. So most of the methods that have been used are not real effective. And so it's mostly going to be subjective, asking your people, your patient in the study, how are they feeling? Some other things, malabsorption, you can do like intubation studies, look at ileostomy patients, not very good. Breath hydrogen is what's typically used in lactose intolerance. So, breath hydrogen, if there's lots of fermentation going on down in the gut, you can measure breath hydrogen. It'll give you some idea of fermentation. The blood short-chain fatty acids, not very good. Fecal pH, things like that, not very good. All these things are going to affect your protocol, how you actually give this. Measurement of endpoints, whether you have stools. And I just want to, this is a study that Holly Grabitsky and I did, and we tried to put together all the data we could find on what's your tolerance to these different low digestible carbohydrates. You can eat a lot of fiber. Your digestive tract is quite adaptable. So vegetarians eat up to 80 grams of fiber. So you can really, if you adapt, you've got a lot of exposure potential there. There's no UL. We don't have an upper limit in the US of how much fiber, and most people are at the low end. They're not at this high end, so it's fine to go much higher. Polydextrose, which is an isolated fiber, they have studies, they can go up to 50. People don't even have problems. It doesn't bother them at all. Fructooligosaccharides are people tend to be much more susceptible to those. So when you're looking at how much fiber could you give a patient, if it's fructooligosaccharides or inulin, there's some studies, 10 to 15 grams per day is probably where you want to be at. There's one study that found diarrhea at 40 grams a day. So all fibers are not alike, all FODMAPs are not alike. There's real differences in exposure here. Fructose, it's really hard, but usually what you can get without just taking it isolated, you're not going to have problems. But for fructose, if you're in like the 50 gram range, you're probably going to have a problem, but not many studies have done that. And then sugar alcohols, these studies are done typically differently, but generally around the 50 gram per day range is where you run into problems. And if you're eating sugar-free gum, it's very hard to get that. You'd have to eat like a whole bag of candy to get there, but you know, people do that. That's, you know, so if somebody ate a whole bag of sugar-free candy and said, boy, I've got horrible diarrhea, you shouldn't be that surprised. You would expect that. That would be an expected outcome. This is a study we did on one of my grad students where we looked at chicory inulin products, and we gave either the short chain and the long chain at breakfast and just in their orange juice. 5 grams was well tolerated for everybody. So a 5 gram dose, no problem at all. 10 grams of the shorter chain. The shorter chain typically is more fermented than the longer chain. And 10 grams caused some symptoms compared to control, more flatulence and more bloating. So I think that, you know, that dose is typically pretty well tolerated in most subjects. But, you know, like in the US, we have some products where you have 9 grams of inulin in each chocolate bar. So people, and it tastes great. Inulin tastes really good. So if people don't know, they don't read labels, you can actually get way beyond the doses that cause problems. I want to finish up on irritable bowel. This is where there's the most interest in FODMAPs, and probably, you know, for the average person, they're not getting enough fiber anyway, it's not a big deal, but irritable bowel is common chronic digestive disorder, problems with motility, sensitivity, lots of problems go along with it. Typically, you go between constipation and diarrhea, which people think, well, how can that be? So people get constipated, then they get and it's really hard to manage, and it absolutely affects quality of life. Little bit of research on about, you know, 1 in 5 women in the US having, you know, this affecting their life. So it's pretty common. And the usual recommendation is to get rid of FODMAPs, that they may cause you more problem than the average person. This is just, I pointed this reference just to show you how difficult it is to kind of go down these dietary strategies, how you're going to go through this. And there's 2 slides here, and it's in this reference, so if you have a particular interest. But it's basically, it's not that different than what we talked about. You heard some other people, an elimination diet. It's pretty much the same idea of trying to figure out what the trigger is, what's causing people problems. So you'll see there is a 7-day food and symptom diary to try to isolate that. And then once you isolate what you think the problems are, actually excluding that. And then, and remember, this is much more of a clinical protocol than a research protocol, because there are big differences among subjects in the response to taking FODMAPs out of the diet. Then you're going to reassess down at the bottom. And you know, this is the same thing, that this is a long time, you know, because how long does it take to adjust? It takes weeks. So whether you're putting fiber into the diet or taking fiber out of the diet, it's going to take a long time to make sure that, yeah. And you can see, was there improvement, partial improvement, or it actually solved the problem. So, irritable bowel, symptom response with low FODMAP diet versus a standard diet. There's a couple studies that are out there, and I just want to isolate those studies and talk to you a little bit about those. And this was the standard dietary advice versus the low FODMAP advice. So in this case, you know, rather than look at all these dietary exposures, just put this person on a low FODMAP diet, sample size around 40. More in the FODMAP group, 76% than the standard, were satisfied with the symptoms. And what you'll see in these studies is usually you don't get an overwhelming success. You think, well, half the people in the regular other group, standard practice, felt as good. You got 76% in the FODMAP having an improvement. They did have less bloating, abdominal pain, and flatulence than the standard diet. So in this conclusion, FODMAPs may increase adverse symptoms in patients with IBS. So there is some data that if you have an IBS patient and you get rid of the FODMAPs in the diet, there can be some clinical success. But what's the downside here? This is a randomized controlled trial in IBS patients. The intervention group were asked to reduce fructans, so some of the FODMAPs, wheat, onions, galacto-oligosaccharides, the polyols, all of these things, the FODMAPs, reduce them in the diet. And the symptoms were improved, but when they looked at bifido and the bacteria, what they found is the people that took, which isn't too surprising, and when you take the FODMAPs out of the diet, bifido levels in the fecal sample go down. So, I guess it kind of depends on how strong you think the data is. If you really believe in the prebiotic effect and the importance of bifidobacteria, by altering the FODMAPs in the diet, decreasing them, you're going to have an effect there. So restrictions of FODMAPs could result in reduced prebiotic intake, affecting the beneficial gut flora. So conclusions. FODMAPs may increase adverse GI symptoms in patients with IBS. And I think we have enough literature that if you work in patients with IBS, people with gastrointestinal issues, it's something to look at. What's their exposure to FODMAPs? A lot of people have already taken, if you get in, talking about some of the internet sites, there's lots of internet sites out there with patient-driven IBS groups that have already kind of identified this as an issue and say, get these out of your diet. But it's definitely, there's enough data that shows a lot of people with IBS are more have more symptoms than the average consumer on this. But remember that there aren't really randomized trials. There's very little research to support this. Getting into the fiber, I didn't get into the usual fiber recommendations. A lot of times, fiber is recommended in IBS to improve because fiber is thought to normalize transit time. So a lot of times people have found good symptoms relief with more traditional fibers. But the flip side of this is these FODMAPs actually can cause more problems. So if you're giving fiber to people in IBS, don't just give fiber across the board. You probably want to go to more of the standard type fibers, food type fibers, than these really fermentable fibers. And then the concern, I said there aren't very many randomized controlled trials. It's really hard research to do. People's symptoms come and go. So to identify people, put them on a protocol, pretty difficult to do. Lots of clinical observations though, which show some success. It's not that well documented, and lots of people believe that putting all these together doesn't make a lot of sense. That it's actually more confusing because each of these carbohydrates are a little different. What's your exposure? So why put them into this group? Why not just isolate them and go down each path? But I think from a clinical side and dealing with patients, sometimes it can work pretty well. Safety of long-term FODMAP restriction has not been reported, and such dietary restrictions could decrease the consumption of prebiotics. So we do have one study that shows if you, get FODMAPs out, prebiotic intake goes down, and you have less bifido and fecal samples. We don't know the long-term effect of that. Low GI foods, fructose. This is being on the dietary guidelines committee, the decision was not to go down low glycemic for the average person, that it didn't really give us enough data on health benefits. But the glycemic response is important to some people. Fructose is the most effective at decreasing glycemic effect. It really works well. Fructose in general is a negative. So this kind of area gets a little bit confusing. But for fructose, if you take that out of the diet, typically the glycemic effect is going to go up. Nutrient-rich foods like dairy. A lot of times people are like, oh, I got to get rid of lactose, so I get rid of all dairy. Mentioned already, calcium's a low nutrient that doesn't get into the food supply, so that's typically a negative going down that. And then just low energy foods, polyols. People may be using these products to reduce calories. So, depending on what the use of those products is, there might be some You know, it might be increasing calories in somebody that actually needs to decrease calories. So it's not as simple just taking them out of the diet. They actually do have some roles. This is the evidence base, and this was from this article, this 2012. So there is some research base here. They're just, if you look at the type of studies that are out here, there are very few randomized controlled trials. I mentioned the ones that have already been published, and you know, these types of challenge trials, which are actually kind of difficult to do. You know, if people have lots of symptoms, to put them on a protocol and say, we're going to give you a challenge and see what kind of symptoms, most people aren't really all that excited to be in a trial like that, so they're less likely to volunteer. These are the references, and I thank you for your attention.